Welcome to the Benefit Whisper. I'm your host, Ralph Weber, and today I am honored to be joined by a true giant in healthcare, Dr. Donald Berwick. Dr. Berwick is one of the most influential figures in American healthcare today. A Harvard-trained pediatrician and health policy expert, Dr. Berwick served as the administrator for Centers of Medicare and Medicaid Services. He also co-founded and led the Institute for Healthcare Improvement, advancing patient-centered care and global healthcare equity. His work continues to be shaping national conversations around value, equity, and integrity in the healthcare system. Thank you, Dr. Berwick, for joining me today.
It's my pleasure, Ralph. Thanks for having me.
So let's jump right in here. For the listeners, Dr. Berwick, who might not know your full story, could you share a little bit about your background and why fixing healthcare has been such a central mission for you?
Well, that'll take all our time to go into the details. I'm the child of a physician, general physician in a small New England town. I always wanted to be a doctor. I absolutely love taking care of patients, but I kept noticing things went wrong. And so in a long time ago, 40 years ago, I got interested in why things went wrong and how we could prevent them from going wrong. I became familiar with the modern methods of quality improvement and quality management that had actually taken root in other industries, not in healthcare. And with several colleagues around the country who remain friends and colleagues today, we started a nonprofit organization, the Institute for Healthcare Improvement, IHI. IHI.org is the website. Its mission has been to try to improve healthcare around the world, and it's thrived and grown and is a wonderful place. I'm now a senior fellow back at IHI after leaving Washington. And it just is, we could function much better than we do. And the data are very disturbing. American healthcare especially falls so far short of what it should be doing. We are much, much too costly, and our results are nowhere near the world-class results they should be. So I
agree totally, Dr. Berwick. I did some research. Every minute in America, a family declares bankruptcy due to medical reasons. Every minute of every day.
It's a stunning story. 110 million Americans in medical debt. And no other country there isn't any other developed wealthy country that has that problem.
No.
Everybody else has solved that. And on the quality side, we join many other countries in underperforming, but despite our expenditures, we're still pretty much at the bottom of the heap. Our life expectancy is about, I think, 40th in the world. Child health status is nowhere near top in the world. We're spending double the money of any other country, and we don't get the results.
A lot of money, $5 trillion a year, over $5 trillion.
It's stunning.
It is. In your experience, how's the culture of profit seeking? And I read your JAMA article a couple of years ago, Salve Lucrum, which was very, very fascinating. In your experience, how's the culture of profit seeking evolved within healthcare over the last few decades?
Well, I don't think it's simple, but I do believe that profit seeking, profiteering, the acquisitive behaviors by people who want to make a financial return on healthcare, and that's their only goal, is distorting the system and at the root of a lot of our underperformance, even more of our enormous costs. It's a profiteering system out of control. Further, it's regressive. I would say American healthcare is the biggest machine perhaps we've ever had that transfers money and well-being from the poor to the rich. So it's a root cause.
Yeah, I agree. You have famously called out institutional greed in healthcare, and this kind of leads in. So how would you define that in a way that people can understand? How is that greed taking away from the care that they deserve and should be getting?
Well, let me give you a specific example. First, in my writing and my teaching, I point out there isn't any sector of healthcare that's free of that kind of greed. I got to make the point, Ralph, that this is in the hands of generally very good people, physicians, nurses, a lot of people who run healthcare systems. They really want to do well by their communities, but something about the financial system has gone out of control. So, for example, we see it in the pharmaceutical industry, making miracle drugs that save lives, extraordinarily important industry, and yet its profiteering appears largely in its pricing behaviors, in which we're paying in this country many times the costs of drugs that other countries do, and it's very exploitative. Yes. Effective monopolies develop, and the companies have no restrictions on price. That's one. Another is the Medicare Advantage world, which I've written a lot about.
Yes.
Medicare Advantage, you will recall, is the private side of Medicare. It's where the government takes our money for Medicare coverage and then gives it at our request to private insurers who then take the money and support the care. But what we know now from really 2 decades of research is they take a tremendous return on that investment.
Right.
The oversight committee set up by Congress for Medicare says that Medicare Advantage, which today covers about half of the people on Medicare, gets overpaid compared to regular Medicare by something around $100 billion a year. $100 billion a
Wow.
year. And that's being taken in by these companies and put into growth and profit and return to shareholders instead of patient care.
Yeah, that's incredible and not in a good way. How do you differentiate greed compared to waste, fraud, and abuse? How does it fit in? I know it's hard to
Yeah.
quantify, but
Well, I don't have any biblical reference, but so I think that some of what goes on in healthcare is fraudulent. It's illegal.
sure.
People sending bills for care they didn't give.
Mhm.
There's actually an industry of that. It's not an enormous number of people, but they're very good at it. When I ran Medicare and Medicaid, I could see it cases of people getting away with crimes. But most of this excess cost isn't criminal. It isn't even illegal. It's exploitation of the legal way we've set up the care system. On the Medicare Advantage side, for example, a lot of the $100 billion of excess payment comes from upcoding, from insurance companies that have Medicare Advantage programs, and they simply figure out how to add more codes to your medical records so that
Right.
CMS pays them more. And they basically are generally following the rules. The rules are wrong. The rules
Mhm.
allow them to upcode.
I see.
And another is delaying payments or denying coverage. Legally, it's wrong, but it's legal. And we let them do it. And then they keep the money instead of giving the care. So a lot of what I'm calling greed is exploitation of existing loopholes. The same goes for hospitals. Hospitals, God bless them, they save lives. Also, we need a robust hospital industry, which by now in the current administration is under tremendous threat. But hospitals, like other businesses, try to consolidate, gain market share, and then use market consolidation as a way to raise prices, which is generally legal. We haven't passed laws strongly to forbid it, but it is exploitative.
I agree. And, you know, we see the government stepping in and breaking up monopolies such as Microsoft years back, but they're not breaking up the healthcare monopoly. I'm not sure if you saw the legislation passed recently in Arkansas about PBMs not being able to own pharmacies. You know, I think that was a good move on a state basis in Arkansas.
Yeah, I did not see the Arkansas change. I should. I'm sorry. I'll go back to my books and study it.
Yeah,
But the PBM, the Pharmacy Benefit Management System, is another example where an intermediary enters the picture, the benefit manager between you and the drug supplier, the medication supplier, and adds their overhead costs and their profit and their, in the case of PBMs, enormous amounts of profit
yes.
taken off the top. Generally not in most states or in the nation doing something illegal, but it's the same kind of we get what we pay for, basically. If we
Right.
have
Yep.
payment systems which allow this kind of profit seeking behavior, we will get profit seeking behavior. Another
Yes.
example is private ownership of hospitals and nursing homes and programs like autism care programs by private equity companies. That also is legal right now. Private equity is where people concentrate piles of money on the behalf of investors and then buy things expecting a pretty high return on that investment.
Right.
Private equity owns about 10% of American hospitals. It owns a
Wow.
larger share of American nursing homes. It owns most of the autism care in this country. And those people that now are the owners of the care you're getting, they have one goal and one goal only, which is financial return on investment.
Sure.
They'll do whatever it takes to get that return, and that does not include at the top of the heap making sure you get the care you need.
Right. And it should be first and foremost. I mean, it's a basic human need. We all need healthcare at some point in time.
Well, it's a unusually controversial assertion in America. Unlike any other Western democracy, we are not a country that has said healthcare is a human right and guaranteed it.
Right.
We guarantee elementary schooling in this country. We guarantee safe roads. We take public responsibility for the safety of our skies, but we don't have a public commitment to healthcare as a human right. Instead, we treat it as a consumer good in which market behaviors and winners and losers dominate and in which there is no guarantee. I'm not guaranteed access to a television or even an automobile in this country. That's not a human right.
Right.
So which side of that division are we on? I unequivocally come down on the idea that the preservation of health and the care of people who are ill should be a complete public commitment in this country, and it should be a human right. That doesn't make it free, and it doesn't make it obvious exactly what that right extends to. But I think it's essential in a civilized country, and we do not have that. As of today, we have well over 20 million Americans who have no health care coverage. That did get reduced to 20 million from more like 50 million by the Affordable Care Act, but it's under threat. And you see today in this administration, for example, dramatic cutbacks coming in Medicaid,
Right.
threat to Medicare coverage with the subsidies that allow people of lower income to get access to Medicare. And if the current legislation and the direction of the current administration go into place, we're going to see tens of millions of Americans, again, without health care coverage.
Right. I read something about the number of people, 8.6 million more uninsured due to the Medicaid cuts.
It's speculative. We have,
Right.
it's all prediction, but yes, I see the same numbers that will come from changes in policy, such as requiring work requirements in Medicaid, which actually make no sense at all. Over 90% of Medicaid families are already working, and those that aren't working can't work. And yet we're going to go put people through tremendous enrollment hoops to prove that that they're working or that they can't work. Same for barriers to re-enrollment. Medicaid families, instead of finding an easy route to asserting their access to Medicaid, will have to now, under the new rules, may well have to go through many administrative hoops that many won't be able to pass through. They're not going to have the receipts and the income
Right.
statements that will matter. Add it all up, all these attacks on Medicaid and CHIP, the Children's Health Insurance Program, and yes, 7, 8, 10 million is not a bad number. Is not an incorrect number for how many are going to lose coverage.
Right.
In addition, we have inadequate coverage. So yeah, you may be covered in a Medicare managed care plan, or maybe by a commercial insurer. But when you actually go to need the care, as all too many people know, you find there are gaps. You actually can't get the care that you thought you had access to, and you're left high and dry, or in deep debt, or, as you said, Ralph, bankrupt.
Yeah, absolutely. And it's a sad state of affairs. What hope do you
And I
see
just,
for?
I'm sorry to interrupt you. It's a sad state of affairs, but I want your listeners to know this is not the case in any other country. People say, well, that's just the way the world works, or it has to be that way. No, we're the only country where these statements are true. The
Right.
only developed country.
Absolutely. Absolutely. What real hope do you see for curbing the greed in healthcare? Could congressional action or even this week's executive order on drug pricing with global standards actually spark reform? Or will it take litigation, such as the fiduciary lawsuits, to drive the change?
It's going to take both litigation so that current laws that do protect people who need care get enforced, and congressional action. For example, Medicare Advantage won't be reined in until Congress instructs CMS to change its coding systems so that the abuses are not there. In terms of guaranteeing coverage, we need laws that do that. Right now, the current budget is going the other way, saying that it's okay to have these barriers to Medicaid re-enrollment, or to decrease the needed subsidies for lower income families to get access to Medicare. So yeah, it's law, it's regulatory enforcement, it's litigation, but most of all, the missing element here is an activated public. Our Congress in the end supports the things the voters tell them to support, and right now the voters are all too silent. They've disconnected the alarms. They realize they think it has to be this way, but no, it doesn't. And we need people in government, in Congress, and in the executive branch who are told by the public that healthcare is a human right, and darn it, they're responsible for creating the regulatory and statutory framework to make that so.
Absolutely. And you've worked globally, Dr. Berwick, in healthcare. You've seen different countries do it different ways. And of course, as you pointed out, they're not all that profit. And again, I have no problem with reasonable profit. It's the greed where the middlemen are getting more than the actual doctors that are providing the care.
There are almost as many healthcare payment systems as there are countries. Every one of them performs better than we do, but some are basically the government has taken over the insurance function. The government is your insurer. In England or Scotland or Wales, if you're a citizen there, if you're a resident there, you have health insurance that the government provides, the National Health Service.
Mm-hmm.
In all of those cases, you can, in addition to that, if you want, as you said, Ralph, buy into the private market, add in some private insurance, but
Sure.
you are responsible as a collective for insurance. Other countries have done it differently. They've set up a guaranteed requirement for healthcare coverage, which may occur through your employer or through the union or through a social insurance system. But in all those cases, the government's the insurer of final resort. If no one else covers you, the government does cover you. So
Right.
that's how countries like France and Germany and Switzerland achieve complete universal coverage. You just can't be without coverage there, and they have a sense that that's the right way to do it. Some countries, again, England is the strongest example. They don't just have national health insurance; they also have a national health care system, which would be sort of like our VA or our Department of Defense hospitals, which but available to everybody. That's actually rather rare. In most countries, the delivery system is privately owned, almost never for profit. In many countries, for profit hospitals illegal. You can't do that. You can't be a private hospital getting paid by insurance. So there are a lot of variations. There's no magic answer. There are a lot of physicians on our side of the ocean who are arguing we need Medicare for all, that the American version of that would be to take this highly successful program, Medicare, which was probably one of the most popular social programs in our entire history, and say everybody can have it. I'm a little afraid that some of the current administration loves that idea because of Medicare Advantage for all, which would mean we're back to a completely private system,
Right.
not government pay at all. I guess the point is there are many, many successful examples. We're just not one of them right now.
Right, right. Is it possible to realign the incentives, design incentives that align the policy with the patient outcomes? Or is a fundamental restructuring required?
Well, that idea of aligning payment with outcomes has been quite popular to talk about in the past decade or 15 years. Value-based payment, basically, like you don't pay for the activities of healthcare, you pay for their results. So that one form of that is a capitated payment in which we pay you to care for a population.
Mhm.
You decide how to distribute that money, and then we'll watch the health of that population change. Right now, they're not very successful because they're not actually tracking the outcomes and linking payment to that. But more than that, it worries me a little bit because think of it this way: people who are ill, and all of us will be at some point in our lives, especially people with chronic illness who are maybe in many cases approaching it. They're in the late stages of their lives. Their health status is not completely under the control of the healthcare system at all. Their health status is being determined by the circumstances of their community. Early childhood education matters a ton. Workplace safety matters a ton. Elder care and kind of avoiding loneliness for old people, that matters a ton. Transportation infrastructure matters. Our food security, our housing security. Can you avoid being hungry? Can you make sure you have a roof over your head? All of these are the determinants of health. Our criminal justice system is a massive influence on health. So, we need a much more holistic view of health and
Right.
well-being and make sure that the money is going into all of those causal systems. If you do that, yeah, you save money. It's a lot cheaper to be a healthy country than a sick one. But it isn't just paying healthcare right. It's a bigger, more comprehensive view of healthcare in all policies,
Yeah.
health in all policies.
Absolutely. And most of healthcare in the US is provided by employers to their employees. So how can employers, especially those that try to offer health benefits, help push the system towards more ethical care?
Yeah, our history is, as you said, exactly about 50% of employer-sponsored health insurance, and that's kind of an anomaly. It means that if I be in a company that runs laundromats or makes automobiles, and now I'm responsible for helping purchase healthcare on the behalf of my employees. That's sort of weird. And for a long time, non-healthcare companies have had benefits offices where they're trying to help guide you to the best policy or to cut a good deal with you for the insurer. It hasn't worked out all that well. In fact, in the current situation with really bad policies and bad payment, we haven't seen the corporations that pay for healthcare for so many employees step up and say, that's enough. We don't want to be the most expensive country in the world by double. It means I can't pay my employees as much. I can't compete on the
Sure.
scale. We want healthy employees, not ones who are struggling with their health, and really insisted on policies that support health and reduce greed. That hasn't happened. It could happen. It could happen. I sometimes wonder when the day will come when the employers of this country, if they're going to stay in the game, stand up together and say, no, we should have the best healthcare system in the world, not the.
Right, right.
It hasn't happened. I don't know if that will happen, if history predicts the future. I'll happy to see it, happy to see them step up, but we haven't seen that happen. I think it's going to have to be more political force and government action that actually will reform the system.
Right. Absolutely.
We haven't touched on one other thing, which I feel as a matter of conscience I should mention, which is
Sure.
obviously, as one of the wealthiest countries in the world, we have some responsibilities for countries that are far less healthy less wealthy than us. And, for a century, we have been an actor in the world, generous in our policies toward countries where a dollar can go a long way in saving lives. We've done that through USAID and through the United Nations functions and through bilateral donor relationships. This administration has cut the heart out of that. It has, I think, murderously stopped the work of the USAID, the Agency for International Development. It has stopped PEPFAR, which is this glorious program started under President Bush to save lives of people with AIDS around the world who could be virtually cured. We are not behaving with respect to the other countries of the world as the support for health on the planet that we really need to be. Part of that is climate change, which the World Health Organization has declared is the greatest threat to human health on the planet. And here we are backpedaling on wind power and solar power, aiming toward burning more fossil fuels and not helping the renewables industry develop. So our policies with respect to our health and the health of people around the world go a lot farther than whether Medicare pays properly, as important
Sure.
as that is.
Absolutely. Huge issue. What do you think, Dr. Berwick, is the biggest myth that Americans still believe about choice in the healthcare system?
About choice. The biggest myth is that we have the best healthcare system in the world. We don't, not even close. And that the rapacious costs they're paying are somehow necessary for the care they're getting. What was the particular focus you just added to that?
Well, I think that American employers like to believe that there's choice. And I think they might define choice as Blue Cross versus United Healthcare versus Aetna.
Yeah.
That may be the choice that they're referring to, or choice of deductibles, copays, et cetera.
So the myth about choice, it's a complex question, a really good one, Ralph. First, I don't believe that whether you live with a heart attack or sepsis or cancer should depend on where you happen to go for your care. There's no reason why we couldn't have a really reliable system. It doesn't matter where you board an airplane, you're going to be safe as long as we
Right.
don't cut the heart out of the traffic control system. We need that level of guarantee so that wherever you go, it's going to be great. There's no reason we couldn't have that. Right now, the idea of the choice is introduced to the American public, and I think this is a misconception, with the myth that markets will solve the problem, that if somehow we put out the information and everything gets transparent and people can move their money around, that the healthcare system will improve. That's a myth. It's wrong. Markets have very limited role in healthcare nowadays. It may have to do with the amenities you get, but not with the care you're going to get. And in the end, for many Americans, they don't have a lot of different places they can go. They're in a rural area where there's just one hospital, or they have a particular disease. There's only one hospital in town that actually takes care of. So we have to give up this myth of the market as the answer. It's very deeply penetrated in American society, and it's very hard to fight it. You're called what, socialist, communist, or whatever the particular labels are. But
Right.
no, it's just science. And that myth that markets will save us, time to let go of that.
Right. Okay, interesting. So if you had 60 seconds in front of Congress today, what would you urge them to change immediately?
Not sure I'd last 60 seconds in front of today's Congress. I think we have to go back to the fundamentals you and I talked about, Ralph. And this country has got to declare healthcare to be a human right. And this Congress should not tolerate any American not being covered for their healthcare costs. Second, we've got to get costs under control. And the way to go on that is to get prices and the greed behaviors we've talked about under control. So we then have the money to put into the social determinants of health and can make sure that people aren't hungry, people aren't homeless, people aren't unable to buy the meds that they need. The money's there. It's just being squandered right now. So I would tell this Congress, I've got a deal for you. You're going to spend 20% of GDP on healthcare. It could be 15, and we could have total coverage and far better quality for everyone. If you start by believing that, then we can navigate policy to get us there.
Right. And I see all the time, just, we were speaking about PBMs earlier, they're spread pricing, they're, keeping the rebates, Humira, which could cost be pricing as low as 19 cents a month. But, even regular pricing, it's way lower than the 10,000 that some health plans are actually paying.
Yeah, it's ridiculous, and we tolerate it. And I tell Congress to stop tolerating it.
Right.
You mentioned PBMs. It always does amuse me. I ran Medicare and Medicaid, for Pete's sake. I'm supposed to understand this country, but when I go to the drugstore counter to pick up my med, I feel like I'm playing roulette in Las Vegas. I have no idea what that cost is going to be. None.
Yeah.
And
I think it's the only thing in the world where you don't find out what the cost is until 7 weeks after the procedure or Yeah. If you talk about if markets were to function, there's no market in that. Not knowing the prices up front, there is no market.
No,
So
it's a myth of a market. I
it
tell
does not
Congress
make,
that if you want a deal for the American people, let's have national health insurance, at least as an option. So anyone who wants to buy their insurance from the US government with guarantees about access and cost and prices can do that.
right, right. And I've lived in 5 different countries, so I've seen, it for myself, not from your perspective, but definitely as a person participating. And it doesn't, to use a phrase that you use often, which I love, it doesn't make us feel safe and protected.
No, that's the Buddhist
Right,
prayer. May I feel safe and protected. And right now
right,
in healthcare, unfortunately, it's not because of the people. By the way, your doctor, your
right.
nurse, even your hospital leader, they want you to be safe and protected, but we haven't set up a system capable of letting them do that. What countries have you lived in? I can't help asking.
Well, I'm Canadian. I was born in Canada. I grew up in Thailand, Nepal, and Germany. Came back to Canada, and now living in the U.S. for 20 years.
Interesting. Well, you've seen a lot,
I
and
have.
you mentioned, Thailand and Nepal. I mean, those are countries with lots of troubles now. But if you actually look at healthcare systems in low-income countries, there's some lessons to learn. They're
There are.
very innovative and
Yeah,
a lot to teach us about how to help people feel safe and protected.
absolutely. Absolutely. And they do have, they used to call them underdeveloped countries or third world countries. I never felt that way, growing up in Thailand. Not at all.
Yeah.
They in many ways they they're, far ahead of us.
If our listeners could suspend their disbelief long enough to say, wonder how they do that. How do those other countries, the 197 or what it is, other countries in the world, how are they trying to make people feel well and healthy and safe and protected? We have a ton to learn.
Well, yeah, absolutely. I mean, even if just looking at the happiness index. So, how about AI? Is there any hope to AI helping us at all?
A ton. I was on a committee in the 1980s on the future of the electronic record. It was going to save us all. So we've got a lot of unmet expectations. But I think this development of AI and generative AI, the newer forms of AI, I think they hold promise. Already, we're seeing the development of record of ambient listening, in which you and I can have a conversation. Then later, AI will generate a report on a conversation that I don't have to go back and put in pajama time at home to write down what Ralph and Don said to each other.
Right.
That's working quite well, actually, already in healthcare. Yeah, decision aids, I have some promise for. We always should have a human in the loop right now. But, if I see a person, if I don't practice anymore, but if I saw, a kid with swollen eyes, there could be 8 or 10 different things going on there. And I'm not smart enough to keep them all in my head, but
Sure.
AI is. And so
Yeah.
the ability to help with diagnosis and with treatment, say, well, if given this circumstance, this is the best course of treatment, all of that could be steps forward. We even have artificial intelligence now doing things like psychotherapy, which, everyone knows that it's a machine, but it actually turns out to be quite effective. And machines can produce an aroma of empathy, which actually people benefit from.
Right.
However, it also can be used badly for billing, for implementing greed, for
Right.
we have some pretty bad AI stuff going now in pre-authorization and insurers.
Right.
So this has to be regulated, studied, and researched on in terms of quality. But if
Right.
we keep our wits about us, I think there's a lot of potential good in that.
Absolutely. And what we use AI for is we use it to scan bills for unnecessary care, usurious charges, too many units
Huh.
of this treatment or that treatment, which is not reasonable. We scan all bills so it compares it against others. So, there are good uses
Yeah.
in that way in terms of billing.
Even before the modern, so I was administrator of Medicare and Medicaid in 2010, 2011, already a decade and a half ago. But we had a program integrity center which worked on fraud and abuse. And when they connected our data to the machines that we actually we tried it at Oak Ridge National Laboratories, which had very high computer power, in a 1 minute run, those computers could spit out what you were just talking about, suspicious patterns of behavior, which turned out to be areas of misuse and fraud, enough to keep the FBI and the Department of Justice and the Inspector General busy for a long time. So
Right.
yeah, absolutely, we can use it to study
Wow.
patterns.
Excellent. Well, this, one final question, and this is just speculative. Anything to be read into the United Healthcare chief stepping down?
Well, yeah, I don't know exactly why he stepped down, but I'll assume it has to do with United stock value, which has fallen dramatically. They overreached. I think that United got into trouble exposing itself to lots of risks of, in some cases, proper regulation, because they were really skating on thin ice with respect to some of their coding behaviors. But I think the investors will run the show. And when the money's not there, they will take action on the executive. That doesn't have much to do with making healthcare better. That just means that the money didn't go into the pockets that they wanted it to go into.
Correct.
I don't know what else to read into it. I mean, United's a good case where I think they're the fifth or sixth largest corporation in America, not the largest healthcare corporation, the
Right.
largest corporation. And I wish that they would make their mission, making what matters to patients happen to patients, that they would stop this acquisitive, constant seeking of the dollar instead of seeking health and well-being. They have the data, they have the money, they now employ tens of thousands of doctors or contract with them. They could do a ton. That's not what they're working on.
Yeah, no, and I think we saw the anger spill over to the Howard Beale level. Do you remember that movie Network? I'm mad as hell. I'm not going to take it. I think in December we saw that with the assassination.
Yeah, I mean, it's tragic, unacceptable. It is not the
Absolutely.
way America should solve problems, but
Yeah.
it may be a sign of how high the anger has grown.
Absolutely. Well, Dr. Berwick, this has been great. Thank you for being here for today with us. But before we wrap up, if folks want to learn more, follow your work, get in touch, where's the best place for them to find you?
I think actually still through the Institute for Healthcare Improvement, where I'm senior fellow. So it's ihi.org. ihi.org. Go there, enroll in the institute. It's free, and you can search for many of the papers that I've written. And if any viewer really wants to contact me directly, it's just donberwick@gmail.com.
Okay, excellent, great. Well, listen, thank you so much for sharing your experience, wisdom, and vision for a better system today. And for everyone listening, if you like what we've talked about today, it's not just theory. It impacts your premiums, your care, your future, your health. I'm Ralph Weber, the Benefit Whisperer, and if today's conversation struck a nerve, share it, subscribe, reach out. You can always reach me at ralph@thebenefitwhisperer.com or call 832-924-3330.
I should mention, Ralph, as you said that, I now do a podcast with my colleague Kate Armate, which I hope will someday achieve the level of excellence you have. It's called Turn on the Lights.
Turn on the lights.
Turn on the lights, and it's a weekly podcast, and we try to get into the issues that we think the general public should understand.
Excellent. I would love to tune into that and hear a little bit more. Thank you for sharing that. Well, the more we spread the truth, the faster we change the system. And let's face it, change is long overdue. So thank you again for joining us today.
My pleasure. Thank you.